Welcome to the Health Leader Forge, where today's health leaders help to forge the leaders of tomorrow. I'm your host, Mark Bonica, of the University of New Hampshire's Department of Health Management and Policy and the Northern New England Association of Healthcare Executives. Our website is healthleaderforge.org, where you can find information about subscribing to the podcast, links and information related to the episode, as well as our complete archives. Today's guest is Joni Spring, the Director of Outpatient Nursing and Clinic Operations for Dartmouth-Hitchcock Medical Center. Dartmouth-Hitchcock Medical Center is a large academic medical center, and Joni's responsibilities include all of the outpatient nursing operations. Joni has had over 30 years of experience as a nurse, most of that time as a nurse leader and nurse executive. In this podcast, we talk about Joni's passion for nursing, a field she always knew was going to be her life's work from the time she was a small child. I really enjoyed talking with Joni because she is so clearly an authentic leader. She is quite candid in the interview about her many successes, as well as some of her most difficult failures. Her story is well worth listening to. I hope you enjoy it as much as I did. And if you do enjoy this podcast, won't you leave us feedback on iTunes, Stitcher, SoundCloud, or wherever you may be accessing this recording? It helps other people discover the podcast. Thanks for listening, and here is Joni Spring. Welcome to the Forge, Joni.
Thank you. I'm really excited to talk with you today.
I'm looking forward to it, too. So you are a wildcat.
I am a wildcat. Once a wildcat, always a wildcat.
All right. So you did both your Bachelor of Science in Nursing and your Master's of Science in Nursing with my neighbors downstairs in the Department of Nursing at UNH. What drew you to UNH to initially pursue your BSN?
Yep. So I grew up in New Hampshire.
Okay.
And so I grew up in Ware, New Hampshire.
Okay.
Everyone laughs when I say that. So it's kind of between Concord and Manchester. But I grew up in Ware, so I'm a New Hampshire born and bred. And I really never even thought about going outside of New Hampshire. Like it was always, that's where I was going to go. I was accepted to St. A's, UNH. I think those were the two. And I chose UNH because I felt like it was a little farther from home for me, because St. A's was a little too close to home. So there was never really a doubt that UNH was, or that I'd stay in school in New Hampshire. Okay.
And why nursing? What drew you to what made you want to be a nurse at a young age?
I don't even know how to answer that, because ever since I was 3, ever since I was able to talk, this is what my dad tells me, I wanted to be a nurse. Okay. I had a lot of family members who were nurses, so it's not really a shocker. So about 3 of my aunts were nurses, and it was just always something. I think I was born wanting to be a nurse. Like it was just, I never even thought about a different career. Not even in high school or even in my 30, plus years of being a nurse, I've never questioned, like, I am a nurse at my core. Like sometimes I feel like I'm a nurse before a mother or a wife or whatever. And I'm not, but nursing is just, it's part of my core. It's who I am.
What did that mean to you as you went into the program?
What
did you imagine it would be?
It was, I wanted to take care of people. I've always loved people, I was the oldest child, of 4. So, that could be part of, as an oldest child, you're kind of helping, your siblings. And, but I loved being with people, number one, and I loved taking care of people when they needed it. Yeah. And I don't know where that came from. It's really just, I feel like it was just my calling. And so in nursing school, I found nursing school very easy. Okay. Doesn't mean it wasn't challenging or it wasn't difficult, but it was my passion. So it never felt like hard work. Even nursing today. So it's just a natural fit. Yeah. I mean, not that there weren't challenging parts of my career, some of which I'm sure we'll talk about, but even as a caregiver, as a nurse, I loved the most difficult patients, or the patients who other nurses were like, no way, I need a break. I always felt like I had something to offer them. Okay. So you were from New Hampshire. You always knew you'd go to school in New Hampshire. And then as soon as you graduated, you left New Hampshire and went to Philadelphia. I did. Where you worked at the Albert Einstein Medical Center. So what drew you down to Philly after that commitment to New Hampshire? Yeah. So a couple of things. One, I'd grown up in a small town in New Hampshire. All my friends in high school, now my high school class was 30 people. So they were all marrying each other. Like as I was headed off to college, they were all getting married. And I'm like, oh, no way. I got to get out of here. So I just remember thinking, all right, I'll go to college and at least I'll be kind of away from the townies is what I call them. And then so a couple things. When I graduated, I thought this is really my time to try and get out of New Hampshire for a little while anyway, explore the world. That's when you're supposed to be doing all that fun stuff. And then at the same time, when I graduated, Massachusetts had a hiring freeze. I think it was Proposition 2.5 or something like that. So it's hard to imagine today, a hiring freeze in healthcare, but they did. They were not hiring nurses at all. So to get a job when I graduated in 1984, when I graduated, was tough. So I went to a job fair. I don't even know where the job fair was. It might have been at UNH. They often had job fairs. And I met a recruiter from Albert Einstein Medical Center who said, we'll give you housing for 6 months. So I'm fresh out of college, my very first job, stressed about money, right? So I'm like, okay, you're going to give me a sign-on bonus. You're going to pay for my housing for 6 months, which is but anyway, they did. And to boot, they're going to hire me into a specialty that I wanted to work in. I wanted to work in pediatrics. Okay. And typically, the industry standard is that we don't hire new grad nurses into specialty areas because of the need for experience. And it isn't that it can't work or it doesn't work. It's just that wasn't the glide path at the time. Yeah. The glide path at the time was get 2 years of med surg and then specialize. But they were willing to train me, to give me the education, and I could start right in pediatrics. Wow. So I'm like, I'm in. So that's how I ended up in Philly, and it was a great 3 years of my life. It was our 2 years, 3 years. Had fun, met, lived in Center City, Philly. Actually, I lived a little outside on the outskirts, but it was a great career. It was a good career move for me. Yeah. I learned a lot. Big culture shock, though.
Okay. So coming from small town New Hampshire, Durham, UNH is in a small town.
Right.
All of a sudden you're plunged into one of the bigger cities in the country.
Yep.
And in a big med center as well.
Yeah. So I grew up in New Hampshire. I came from a nuclear, actually my parents had divorced when I was young, but typically in New Hampshire you have mother, father, children, at that time, divorce, mixed marriages, like that just wasn't what I grew up with. So I found myself in Center City, Philadelphia, taking care of a lot of children who were abused by their parents, which is really hard. And at that time, I worked in the intensive care unit. So some of those kids lived there. So we were like their parents for 6 and 9. They were in the hospital for 6, 8, 9 months, a year. So they became like our kids. We became really close. The nurses became really close to the parents. And this is where I learned about boundaries, patient, because I was all in, there. So if a baby died, for example, I would go to the funeral. And that was a culture shock because they were not like Catholic churches like I was raised. They tended to be very different, just very different religions that I wasn't exposed to. Singing like hallelujah and this is great. And I'm thinking, I just remember looking around going, what am I doing? It was just really, it took a toll on me. Yeah. I probably went to testify in court about 4 times in my first year there because I was in the middle of the father hit the mother. I got hit once because the boyfriend was trying to hit the father and I stepped in. This is all
in the ward?
Yeah. And I stepped in to protect the mother and the kid and I got hit and it was just a completely different social structure, social environment that I was used to. And
what was the socioeconomic status of the average patient then?
So they were, a poverty level, multiple, a mom with multiple fathers of children and, custody issues all over the place. Like I was not prepared for that. That was just a culture shock for me. Yeah. And, so I found myself getting a little burnt out because I was all in. And I don't regret that, but it taught me a lesson. Tell me
a little more about boundaries. You're talking about boundaries. You said you were all in. Yep. So what did you learn from that, and how did that affect your career going forward?
So I remember in nursing school, one of my instructors saying, Joni, you care too much about your patients. Like, so this started,
and that's a bad thing.
Well, and I said that. I said, that maybe I'm in the wrong field. I said, and I had a moment in my nursing school career where I was like, maybe I've chosen the wrong profession. Because I remember saying to my instructor, if I can't care about my patients, then I don't want to do this. Then maybe I should be a social worker, or maybe I should think about doing something else. But this is who I am. This is who I am, and I don't know another way to not be. So I'm going to keep on keeping on, and I'm going to keep on going being who I am. And thank you for your feedback. It's pretty much what I said to her. Got it? Thank you. Appreciate it. Moving on. And then when I found myself in Philly, and I found myself connecting to the patients on a really, really personal level, and then it began to, that's when I thought back to what she said to me. And I just think that there is a place for some self-protection, right? There is some place for, you can demonstrate compassion. So I learned how to demonstrate compassion and caring without giving up part of myself. And I felt in some cases I was giving up part of myself. I had gone a little too deep with my emotional reserves, I guess, or my emotions. And I did kind of have to just kind of rethink for me, how can I still be true to who I am? Because I will never not be true to who I am, but still be whole, still be able to be compassionate for the next 20 or 30 or 40 years. So I really just tried to put it into perspective in my own way. Like, I didn't learn how to do it. I didn't follow any theory or model. I kind of just learned to self-regulate. I just learned how to, when was enough.
Yeah.
So
you could keep going, keep giving.
Yeah. Yeah. Because that was important to me. But I also didn't want to find myself a burnout nurse that I see, that I had seen in my career. I didn't want to be that nurse. Yeah. I didn't want to be that person who didn't have enough to give at home, or to give to their kids, or to give everywhere. And then the last thing I'll say is the place where I found that I struggled with is, so when I worked in Philly, I took care of pediatrics and pediatric intensive care. So I took care of really, really sick kids. Then when I moved back to New Hampshire, I worked in pediatrics again, and then I started having my own kids. And once I started having my own kids, I found I couldn't do pediatrics. Like, I had a different perspective. I looked at the world differently, having had my own children. Yeah. So I have so much respect for pediatric nurses who stay the course and take care of those sick and challenging kids who have their own. Because for me, that was emotionally, I guess that was my barrier, that was my guardrail.
What was it about having your own kids that
because you're looking through the eyes of a mother now, which is, you could argue that's a good thing, because you could be compassionate and empathetic and demonstrate empathy with parents of children. But for me, it became, I don't know, I can't describe it. It became too personal.
What's the difference between, you said you moved into pediatric intensive care. What's the difference between just a pediatric ward and pediatric intensive care? What's the difference in care level?
Yep, it's definitely the acuity of the patient. So in the pediatric unit, they're up, they're about, they're walking around, they're maybe recovering from surgery or having, recovering from an asthma attack or things like that. Children in the pediatric intensive care unit are much more sick. They can be on ventilators. They're just very, very ill. So they need more like 1-to-1 nursing care. Or on the floor, you could have 1 to 3 or 1 to 4. But in the pediatric ICU, it was very intense. They were very, very ill. Sometimes they didn't make it. Sometimes they did. But it really is their level of illness, the level of treatment that they need, and the level of nursing care that they need.
Okay. So you didn't, as you said, you didn't stay in Philly all that long. You were about 3 years.
Yep.
And then you came back to New Hampshire.
I did.
What brought you back to New Hampshire?
So I started thinking that, it's probably time to think about having, settling down, having kids. And at that time, I wanted to be near my family. I had a big family support here in New Hampshire. And I thought, if I'm going to enter my having children, I hadn't met anyone yet, but if I'm going to enter my phase of having kids, I want to be near my family. Sure. I want my kids to be part of my family's life, and I wanted them to be part of my kids' life. So it really was And I got to say, I missed my family.
Yeah.
Yeah. And it was great to be 3 years was fun. And I met great friends that are still friends to this day. But it was time for me to be back home.
Okay. So you came back to New Hampshire and you started what was about a 28-year run at the Elliott Health System in Manchester, where you worked your way up from being a staff nurse in the pediatric unit, as you mentioned, all the way to being the chief nursing officer and vice president of patient care services.
Yep.
So you said you came back for your family, but what drew you to the Elliott in particular?
Yep. So, well, in Manchester, if you grew up in Manchester, there was the Elliott and CMC.
Right.
So you were either a Elliott, your family generally either went to the Elliott or went to CMC. And my family was sort of the Elliott crowd. And I had done a lot of my clinicals there. So in nursing school, I'd done a lot of my clinical placements there. So I knew the hospital and I knew some of the nursing staff. And it was important to me to live in the community, to work in the community that I lived in. So, when I think about my identity as a nurse, when I talked about how that's central to who I am, like I wanted to work in my hospital. I wanted to work in the hospital that I associated with. So I think I did apply to CMC and Elliott because, you never know.
Right.
And I did not get an offer from Catholic Medical Center, but I did get the offer from the Elliott. So, but the Elliott was more, I was applying for pediatric positions, and Elliott had a bigger pediatric presence. Catholic Medical Center's pediatric unit was smaller. So that's probably why.
Okay.
I ended up at the Elliott.
I've done a couple of interviews at the Elliott, as we were talking about before we started. But for folks who are not familiar with the Elliott, can you tell us just a little bit about what's the Elliott? Where is it, and with respect to Manchester and so forth?
Yep. So the Elliott is on the east side of the city. So the city is sort of split into east and west. So the Catholic Medical Center is on the west side, so kind of divided by the Merrimack River, which is pretty symbolic in Manchester when we think about Elliott and CMC. There's still a long-standing rivalry between the two. So when I first started at the Elliott, I kind of want to add a little perspective. It was like the hospital was it. Like it was the center. It was the hospital. So when I first started there, no physician practices, no, ambulatory medical centers, just the hospital. So you went and you worked at the hospital. Fast forward to 28 years later or 30 years later now, the hospital is just a small part of the system. And I remember when that, I remember that transition from it's the Elliott Hospital and some physician clinics to now where the hospital is just a part of the system. It isn't the focal part. There's like 35 or 40 physician practices. There are 3 freestanding ambulatory medical centers with two urgent care centers. So now the hospital is a component of the health system and not sort of the health system. And I'd say probably around, I don't know, maybe year 15 or 20, that started to change. We started as we began acquiring physician practices and building urgent care centers. All of a sudden it was a system and not just a hospital with a few practices. So that was an interesting transition to live through.
Yeah, I bet. So one of the things I like to ask my clinician guests is about your clinical identity. So you've talked a bit about, you've always wanted to be a nurse. But when did you feel confident in your nursing identity? When did you feel confident saying, yep, I am a nurse?
Yeah. Again, I know we talked about this earlier, but I feel like I was always a confident, even as a student, a confident nurse. I do remember as a brand new nurse thinking, I can't wait till I have 5 years of experience. So I remember thinking, like nurses who I met and worked with on the floors that had 5 years, I thought, oh my God, I was in awe of them, just like so amazing that they're like 5 years. That's amazing. And then all of a sudden one year, I'm like, I've been a nurse for 15 years. Like before I knew it, I'm like that nurse that I used to admire, And so I've always been confident, and I always have considered myself a nurse, even as a student. And this is where I believe one of the most important aspects of leadership is being passionate about what you do. And I am passionate about nursing, as passionate today, I believe, as I was when I started in my first year of nursing school,
Wow.
so.
That's a long time to have that passion.
Yeah. As I was hiring over the many years of leadership, that I would look for that. So I would rather hire a new grad with no experience who's passionate and caring than a nurse who has 10 years of experience but doesn't have that spark. Like, I call it shining eyes. Like, I look for nurses who think they can conquer the world, who want to take care of patients, who, like, that's their life's mission. And I hire one of those and teach, because I can teach any skill, right? We could teach you to be an ER nurse, an ICU nurse, a NICU nurse, any kind of nurse. I can teach that. But what I can't teach is that passion. You either have it or you don't. Yeah. In my experience. So that's what I hired for. I hire for fit.
So you came to the Elliott as a staff RN.
Yep.
In the pediatric unit, and then moved on to orthopedics. And eventually you became the clinical nurse manager for the orthopedic unit, a 44-bed orthopedic women's health patient care unit. What was it like to make the transition from staff nurse to clinical nurse manager?
Yep. So, that can be a difficult transition for nurses. I've seen it go well, and I've seen it not go well. I would say for me that I was a well-respected colleague with the other nurses on the floor and outside of the floor. So with the nurses in the ER, or, it's always important to be friendly and nice to everyone. But I was well-respected. I think that's number one. And as a staff nurse, I had always kind of offered to take on a little more. So, volunteering to want to learn to be in charge, or volunteering to be on a committee or to take on projects. So even though I wasn't in a leadership position, I felt like early on I was demonstrating my desire to be part of leadership or to gain leadership exposure or experiences. So by the time I was ready to transition into my leadership role, pretty much everyone knew that's what I wanted to do. You know what I mean? But I took that time, and I think that's really important for leaders too. I believe nurses are leaders no matter what position they were in. So even though I was in a staff nurse position, I saw myself as a leader. And I teach that a lot, or coach and mentor people a lot, that you don't have to be in a formal position to be a leader, that you can lead from wherever you are. And that is what I felt like I did. Yeah. And I think that helped me to be seen as a leader or a potential leader.
Yeah.
And plus, I would tell anyone that would listen that was where I wanted to be.
Okay.
I want to be the CNO someday.
Yeah.
But first, I want Denise's job. So Denise was my first manager.
Okay.
And she didn't leave at the right time. I was 6 months pregnant or 7 months pregnant with my first child. And then she decided she was going to move on to an IT position. And I was like, you're not supposed to do this yet.
Right.
Like I didn't,
Stick around for a couple more months.
Right. Well, I didn't want to even do it for another year,
Right.
But sometimes opportunity doesn't happen when you're ready for it.
So you took on your first supervisory role, formal supervisory role, 7 months pregnant.
I did.
Okay.
I did. And I remember interviewing with the physician leader, the medical director of the unit.
Okay.
And I remember this conversation. I talk about this all the time. I remember when I was interviewing with him, and he was, and I knew him. I worked with him every day, and he was so uncomfortable. And I remember saying, Dr. So-and-so, I'm like, what is wrong? Like, are you not thinking that I can do this? Like, I was really worried because he was so hesitant with me, and he wasn't normally that way. And he goes, well, all right. He goes, I'll tell you, it's bothering me that you're going to be out on maternity leave for 3 months after you take this job. So I was like, okay, this is one of those moments where, like, this is one of those crucial conversation moments that I now know what it was, but I didn't know at the time. But I remember thinking, tread carefully here. And I said to him, I'm disappointed to hear you say that. As a woman, facing maternity leave, it's a little bit different than you as a man. You don't have to make the same decision. I know you have kids. He had 2 little kids. And so I want you to imagine, what if this were you? And what if you had to face the job opportunity that you wanted the most and you wanted, and the timing just isn't perfect. The timing just isn't right. And we had a really good conversation about that. And what I could have said was, well, that can't be a factor here. Like, I could have pulled the HR card, right, and said, you can't say that.
Right.
Right. You can't, like, today, I think if he said that today, he'd be in some kind of, trouble with HR. But I remember saying, that's not fair, is really what I was trying to say to him, is that's not fair. That's not fair. But we ended up being excellent, great colleagues at the end of the day. And to this day, he's still a huge supporter of mine. We still stay in touch. But I just remember that conversation and how hard that was for me to be asked that, to be faced with, here's my opportunity. Like, this is my path. This is where I want to go.
You've been telling everybody.
And it's not the right time. Like, it wasn't the right time. And I even went and talked to other nurse managers who had children while they were working. So I'm like, how do you do this? Is it possible? How do I do this and be successful? So, I was aware, I get it. I was aware that the timing wasn't right. But I just remember that conversation, like, I'll never forget it.
Yeah.
I don't know if I answered the question.
Yeah. Well, we're getting at it.
Yeah.
So you did, in fact, get hired.
I did.
And so what was that transition like?
Actually,
so going from colleague to now supervisor. Yep. In particular, you stayed in the same unit.
I did, right.
Right? So people who yesterday were
your colleague,
your buddies,
yep.
Now you're the boss.
Yep. And I think it was successful for me. Every moment wasn't successful, but it was successful because I had the respect of most of the staff. There were a few staff who, as a leader, you have to performance manage, and, that I had to manage performance, and they'd say, oh, come on, Joni, you know me. And I'd say, I do know you, and that doesn't change the fact that this is an issue that we need to work on together. Like, how are we going to do this? I do know you. I like you. I think you're a fantastic nurse, but we have we have this problem that let's try and solve together. Yeah. So, so they did try, and then they tried testing a little bit, what can they get away with? And it's just so normal, new leader behavior. It wasn't because it was me personally. It was a new leader. Right. And so I always tried to kind of sort through that in my head. Like, is this personal, or is this, they would do this with any new leader kind of thing.
Okay.
So I think because I had the respect of the staff and the physicians, I had a ton, physicians were very supportive of me being in that role. So, there were challenging times. There were times when I had to say no to the physicians, and, that was hard. When I had to sort of kind of do the party line, with budgets, and, that we can't just have everything we want. So, those are always difficult conversations when physicians or staff want something and you have to be the one to say no. Yeah. But that's never easy no matter what.
Talk about that relationship a little bit, even from back then,
yeah.
about the physician-nurse relationship on the ward. What is the relationship between the physicians and the nurses on the ward?
Yep. So I'm going to answer that in two ways. I personally have always seen physicians as my colleague. I have always seen them as my equal. I respect them for their education and the career path that they chose. But in the same vein, I want them to respect me for the career path that I've chosen. So I respect physicians incredibly. Like, I am in awe of what they do, but I'm also in awe of what nurses do. So I never felt personally that power gradient. Yeah. But I have seen it in culture. I have seen it, and I don't like it. I usually try and address it if I see it happening. I think it definitely has changed over the many years that I've been a nurse, where today I feel like there's much more emphasis on collegial teamwork, interprofessional relationships, interprofessional teams than when I first started out in nursing. Yeah. I have always enjoyed the respect of physicians, and I believe that's because I respect them. So would I ever be disrespectful to a physician? I wouldn't, but I expect that same in return. And that's been a good part of my career as a nurse, as a nurse leader. And sometimes physicians, it feels like they don't deserve that level of respect, but I won't do that to myself.
Right.
I won't do that. I will have difficult conversations in a room with a closed door. Yeah. I will address issues. I learned a long time ago that if I had this one physician who was probably the most challenging physician I've ever dealt with, and he was a bully, big time. And he was really tight with the CEO. So it was hard. That was a challenging situation, but we worked it out, and he and I, still have a collegial relationship, but it was, I would say, a little rockier road than I had experienced with other physicians, but he taught me about myself and really made me think about, all right, what do I do when a physician is trying to create that power gradient? Yeah. And I remember talking to my boyfriend or my partner, and he'd say, you know what, Joni, you have to match the level of intensity. So you don't lead with that, but you have to match that level of intensity. So if somebody comes at you with, high intensity, you have to at least match that, because you need to be seen as equals. Yeah. So anyway, it was just an interesting lesson that I learned.
So I teach primarily undergrad future administrators. Yep. So help me explain to them, what are the roles of a physician on the ward? What is the role? How do the nurse and the physician interact on the ward?
Today, in today's healthcare environment, definitely, peers, colleagues. Yeah. So a physician's role is really more, so they see the patient for moments in time, not a moment, but, they come in, they round, they see the patient, and they're generally there for a period of time during a day. But their job, they're not their job, that's the bad word. Their role is, assessment and diagnosis and treatment, so that's what they do. And then a nurse, so I'm going to give you my elevator speech about what nurses do. And I always tell nurses, and I would tell any other profession, have an elevator speech that you can tell someone in 3 minutes what it is that you do. Because I think that's important. And nurses, I think, have an opportunity, or not an opportunity, an obligation to proudly and clearly say, this is what we do. So this is me. This is no theorist, no nursing theorist. This is the world according to Joni. I believe that nurses are the art of nursing. What we do is about being and knowing. So being is being present. So we're the ones, on the inpatient side anyway, we're the ones who are there 24/7 with the patient. So we're with them. It's our presence. We're with them. Patients tell us their stories. You would be amazed at what patients tell nurses. I mean, it's that relationship that you create with a patient. You create a safe space and a place where they can trust you. And I'm just amazed at what nurses that patients will tell nurses that they won't tell a physician. Right. And I believe that's because of the time we spend with them developing those relationships. And as you know, the Gallup poll lists nurses as the number one trusted profession for every year for the last 10 years, except for 2011 when those firefighters. So, which totally get. So that's the first part, is being and learning their stories and understanding their world. So understanding where they live and what they're going home or what they're dealing with in their life. And then the knowing part. So the knowing part is where our knowledge. So what we know about science and medicine and healthcare. So that's where we kind of marry the two. We take the science of what we know, we marry it with what we know about the patient. And that's, in my opinion, where the art of nursing is assimilating, putting it all together. Yeah. And then every discipline has their thing that they do with the patient. So therapy comes in, and physical therapy does the physical therapy piece, and occupational therapy comes in and does their piece, and respiratory therapy comes in and does their piece, and the doctor comes in and does their piece, and maybe a case manager or a social worker. But the nurse is the one that ties it all together, that kind of completes the story, kind of puts it all together and helps. I think her or his contribution to the team is integrating and coordinating all those different pieces and making sure that everything is taken care of. So and that's not always easy, and it's not always,
not.
yeah, but that's what I see as the role of nursing.
Nice.
In the world according to Joni.
Which is exactly why we're here.
Yeah,
we want to get the world according to Joni today. So, in the world according to Joni, you went through a series of promotions over the next 7 years or so. We went from being clinical nurse manager to clinical nurse supervisor, to registered nurse clinical leader, to eventually director of emergency services. So I want to kind of fast forward through those roles. But the way I read that is the first two roles were clearly nursing roles.
Yes.
The director of emergency services, was that also a nursing role, or are you transitioning into kind of a mixed role?
Right. So that was my first sort of transition into really broadening my scope. So in addition to the nursing, or the emergency room, I took on leadership for a post-secondary school. So we had an EMT school. So we had a school where we taught paramedics. So EMT basic, intermediate, and paramedics. And so that was so incredibly rewarding to learn about that field, because I was a nurse, right? Nurse, love nursing.
Right.
But that kind of exposed me to a different profession and learning to advocate for non-nurses. So that was sort of my first foray into, you can be an advocate, and as a leader, you can advocate and support and lead anyone. But that was sort of my first foray outside of the nursing field. Okay. And then I also was involved in building and staffing and overseeing the urgent care centers. So they were, I oversaw the nursing part of them and the operations. But again, it was still, expanding my scope. So started in the hospital, and now all of a sudden beginning to broaden my scope to ambulatory and outpatient and EMT training.
So during this period that you were working in EMS, they were starting, Elliott was starting to build urgent care centers outside of the hospital?
Yes. Yep. Okay. Yep. So, then you start learning about construction and working with contractors and architects, and, so it was a great experience for me.
Who did you report to in that role?
So I still reported to the chief nursing officer.
Okay.
Actually, I'm trying to think. Gosh, there may have been a level in between. There may have been a senior director or something, but generally always reported up through the chief nursing officer.
Okay. How would you say your leadership evolved during that time? So you're now taking on other types of clinicians and providers under your supervision.
Yeah.
You are starting to look at, outpatient and other, and then also the whole EMS school. How did your leadership evolve?
So I would say in those years, the thing that I learned the most about was emotional intelligence and situational awareness, and really learning, because then I began to have more exposure to senior leaders outside of nursing. So even though I reported through to nursing, I had a lot of exposure to the VP of facilities and the chief operating officer and the chief financial officer. So even though I wasn't at the CNO level, my path began, my scope began to broaden, and I learned how to self-regulate my emotions a little more, because I tended to be very passionate about what I do in my work in nursing, and I had to learn sometimes what I think is passionate is coming across to someone else as being aggressive or assertive or aggressive. Yeah. And I remember, the first time somebody had a crucial conversation with me and talked with me about how I was being perceived, I was devastated. I was like, but I'm just advocating for, and they're like, I know, but, it's not coming across that way. So I kind of got sent to organizational development school. Okay. in our institution. Yeah. And I actually learned a lot about impact versus intent. So the organizational development person's still at the Elliott, but she taught me this whole concept of intent versus impact. So she said, what I learned was that I was intending to come across as, passionate and caring and advocating for my staff, but it was coming across so the impact I was having was that nursing was more important than respiratory therapy or whoever, so that somehow I was not being perceived as a team player. I was being perceived as nursing, but that's what I knew. So I, over the course of 2 years, identified about 3 people in the organization who I trusted would tell me the truth, who I trusted would tell me what I didn't want to hear and what I did want to hear. And after every meeting, or maybe not every meeting, but, after particularly challenging meetings, I would go to them and say, all right, how did it go? Like, how did I come across? And so at the beginning, the feedback was probably, not as great. But that's where I really learned how to regulate my emotions, how to wait, not be the first. So I would always be the first one to speak up in a meeting, right? I would be the one who would say what everyone else was thinking, but nobody else wanted to say. Right. So then I found myself in everyone's offices, in the CNO's office or here, like, Joni, are you okay? I hate it when the people start a meeting out like that. Like, that's not good when they ask you if you're okay, because it means they don't think you are.
Right.
But that in those years, I think, is when I learned a lot about how to read a room and how to read, how somebody's responding to you. How is someone, and now I'm really good at that, but I wasn't so good at that then. And I would say those are probably the leadership lessons that I learned the most in those years, because it got me out of my nursing comfort zone and learning really how do you work interprofessionally and how do you work collaboratively and how do you respect the contributions of everyone on the team. And it isn't all about nursing. It doesn't mean that my job isn't to advocate for nursing, but I had to think about sometimes your agenda doesn't rise to the top. So I was always in nursing accustomed to nursing's agenda rises to the top. And I really kind of had to learn. There were times when I had to pull back. Times when understanding the situation at hand, I've learned, so over those years, I've learned when it's time to advance something as an issue or as a proposal or an initiative and when it's not. So I would say those are probably the most important things that I learned in those years.
And you were moving into roles where you weren't just concerned about nursing anymore.
Right.
So you had to kind of expand out beyond that.
So that was learning for me, and again, some of this learning, I don't think you can, you have to live, you have to live and experience through tough conversations and through failure, like, through starting and stopping. And I'm a fan of young leaders. I think young leaders are our future, but, and I'm a little bit type A, so it's hard for me to sometimes say, slow your roll a little. I think you might need to just get some experience under your belt first. And I would hate it if someone said that to me.
Because you were ready.
I was.
So during this time, you also moved from being a first-line supervisor to being a manager. So, and by that I mean you're managing supervisors or even supervisors of supervisors. So, so you're several levels potentially removed from the frontline people who you were ultimately supervising. What was that transition like for you?
I'd say that it was okay. I did struggle at the beginning with letting go. So because I thought if everyone just did things my way and, this was my leadership style and it worked for me. And so why wouldn't you want to do that?
You should just be like Joni.
Exactly. So I had to learn, that there are different management styles and so I struggled with letting go, I would say. Is one thing. And even when I became a manager on my orthopedic unit, I remember the nurses saying, get out of the nurses station and get into your office. They're like, we're good. We got this. You need to be doing different things. Like, this is from my staff, my staff. Yeah. But they're like, you got to let go of this stuff. We got it. Trust us. And so I think that was a lesson that I learned is you have to trust the people that you work with. And they're going to make mistakes, and that's okay, but it took me a little while to learn to do that. It doesn't just poof happen. It took me, and I had some managers who felt comfortable giving me that feedback, and they would say to me, I got this. Or they'd say, do you not trust me to do this? So we had some not difficult conversations, but some honest conversations about, I'm like, oh my God, they don't think I trust them. I can't do that. You know what I mean? So it really learned how to support without directing. Right. And that was again, just takes time, and it takes surrounding yourself with people who will be honest with you. That's also sort of a nugget, is surrounding yourself with people who will say the difficult things and the good things. Yeah. And then you got to be okay moving on. You got to be able to disagree. You got to be able to work through something and then let it go, and then kind of move on to the next thing.
So in 2007, you became the Director of Patient Care Services. What was this role, and where did it fit in the hospital structure?
So the Director of Patient Care Services is sort of a catch-all title. It ended up being. And then so we had 2 directors of patient care services, and pretty much we just split the hospital into 2. So at one point I had these 3 service lines, and then another time I had these 3, kind of depended on who was in what role, what the skill set was. Yeah. So it ended up being a generic leadership title for, you're going to oversee 1 or 2 or 3 different service lines.
Can you give me an example of a service line?
Yep. So maternal child health. Okay. The operating room, or surgical services, med-surg services, critical care services. So those are probably the 4 most common ones. Okay. And that was where I learned that I could lead and manage any service line, whether I had the clinical expertise or not. So I remember the moment when they said, we want you to take over surgical services because someone was leaving. I'm like, surgical services? Never even been in the operating room. So you learn how to get work done through others. You learn how to rely on the clinical expertise of the people in those areas. And your job is to, as a leader, provide resources, remove obstacles, be a coach and mentor. So it kind of helped me to develop my more higher level, what I call higher level leadership, because I wasn't the clinical expert. Right. Not at all. The clinical expert. Then same thing happened when they said, can you take over labor and delivery and maternity in the NICU? And I'm like, okay, so I have pediatric experience, so, but labor and delivery? I was an ER nurse, and we could take care of gunshot wounds and traumas and strokes, but don't give me mom having a baby, which is the most natural thing on the planet, right? But we were like, oh my God, get down here, we're coming up. So I wasn't the clinical expert in those areas. And so just having to learn how to pull together your team and how to respect and value their contributions, and knowing you don't have to always be the clinical expert. I guess that was one of the lessons that I learned during those years.
Yeah, I wanted to ask you about that, because inevitably as you move up, whether you're in the nursing field or administrative, you're going to move into a field where you are not an expert.
Yeah, right? Yeah.
So the keys that you see for that kind of as you move into it is just relying on your people.
Yeah, but I do think you have to have a little bit of inquisitive knowledge. You have to understand some of it. When I took the Norris Cotton Cancer Center role here, I didn't have any oncology experience clinically. I had some oversight, but at the Elliott. But I made a commitment to learning the basics of oncology, so that when I was in meetings and they were using terminology, I had to know, I had to have some level of knowledge about what they were talking about, because then I'm not going to be respected. They're not going to respect me. They might think I could lead anything, but if I can't talk with them about what the issues are, that's a problem. So there is a little bit of, although I'm never going to be an oncology clinical expert, I had to make a commitment to learning about what's a COG. And I remember being in my first meeting, and I'm like, what is a COG? What's a clinical oncology group? So it's breast cancer, GI cancer, skin cancer, whatever. And I'm like, okay, I got that. Yeah. But, so it's just kind of learning. You have to make a commitment. I wanted the cancer center docs and leadership to know that even though I'm not an oncology nurse and I'm not ever going to be an oncology nurse, that I respect their profession. I respect their specialty enough to learn a little bit about it.
Yeah.
You know what I mean? So that was important to me in all of these, is to learn. And I would say you have to be humble. So, humility is another, when we get to the leadership, I think humility is a really, really important leadership quality and leadership trait. And I would say to them, I don't know anything about this, so you got to help me out here. And that's what I'd say to my colleagues or nurses, like, give me like the Cliff's Notes version about whatever it is we're talking about. So that was how I kind of got through, or led through, managing areas that I wasn't the clinical expert in.
So you did that role through 2011, and then in 2011 you became the Chief Nursing Officer and Vice President for Patient Care Services, a role you held until 2015 when you left the Elliott to come here to Dartmouth-Hitchcock.
Yep.
So what is the role of the Chief Nursing Officer?
Yep.
And kind of what are the responsibilities and duties typically associated with that
role
in general, and then were there anything specific about it at the Elliott?
Sure. So the Chief Nursing Officer is the highest level nurse in a system. So they're the kind of the buck stops there, right? There, as a Chief Nursing Officer, you're responsible for practice in your institution. You're responsible for strategy. So strategy, practice, education, so you're responsible for all of nursing. And then I would say that I was the nurse at the table. So I was the nurse, who I sat on the board of trustees. So I was there representing nursing and patient safety and patient quality. I was the nurse with my colleagues. So there was a chief medical officer, chief nursing officer, chief operating officer for operations. And then every organization has different levels, but typically the standard roles are, in addition to those, chief financial officer, chief of planning and marketing, like Susanna. So my role as a colleague is to obviously represent nursing at the table and the patient. So I always felt like my responsibility was to advocate for the patient at the table. Now, you'd think that everybody would be advocating for the patient because we all work in a hospital. But, people, that's not their thing. That's not their specialty. So the finance person, if you have a good CFO, which we did, and I had a fantastic CFO who did understand clinical operations, and if he didn't, my job would be to help him understand this is what nursing is about. So you're kind of helping people understand what nursing is, what we need in order to be successful. Same thing for the patients, advocating for patients. And a lot of it is being the point person. So the point person for everything, and then you delegate that out to your team. And I would say that the CNO role is the same across the country as it is at the Elliott. That it's just being that responsible figurehead. But you're also responsible for growing and coaching and mentoring your team and all of that.
Yeah. What surprised you about that role? So I'm guessing that was kind of, you always had, when you said,
I did,
you always
yes.
had in your mind, that's where I'm going.
Yeah. I think.
What surprised you when you finally put on the hat and sat in the chair?
I was so excited.
Sure.
I think I was just like, at first I was like, this is so cool. And then I think, there are always challenges to senior positions like that. And just kind of negotiate. I guess what surprised me the most was that's really where you begin to see the politics in the organization. Okay. After the meetings and the outside conversations, or what people don't say in the meeting, but then they're going to say outside of the meeting. And I guess that's the thing that surprised me the most, because I'm an optimist from my core. Yeah. And you don't want to believe that things happen for political reasons, and they do. So I think that was probably my most the lesson that I was the most disappointed in, I guess. Yeah. But it is what it is. You kind of got to learn how to navigate through political situations, and using the skills you learn as emotional intelligence and situational awareness, and then I really had to learn what is my core, like what are my core values that I'm not willing to compromise. That's what I'm looking for. What are my core values that that I have to say, if this happens, I can't work here. You know what I mean? So I had to, at that level of position, because there's nowhere to go but out.
Right.
Like if you get to that point, you can't go back down in the organization. When you're at a chief nursing officer or a C level suite, if it's not working, you got to go somewhere else, because it's very uncommon for people to step down in that scenario. So that, having to think about those things was like uncomfortable. It was the first time I'd had to really think about, what would I do? Like, what if this doesn't work? I never a million years, I thought I'd end my career there. Like never in a million years would I have thought, I'm not going to end my career there. I was there for 28 years. I knew all the staff. I knew all the docs. I was well liked by all
the system,
everything I knew, I mean, no position like that are you liked by everyone.
Right.
You know what I mean? But so anyway, so that was.
Okay.
Yeah.
Can you give a couple examples of things you were particularly proud of having accomplished while you were in that role?
Yep. I think the one thing I'm the most proud of was developing the first nursing strategic plan in the organization. And that started for me when I was a staff nurse. Mm-hmm. I always felt like, you see all the mission and vision and the strategy, and it never felt to me like I was connected to that. And I thought, someday when I get to be the CNO, I'm going to connect the dots for nurses so that every nurse who works in this organization knows that what he or she does is connected to the success of the organization. Yeah. So in my mind, that was one of my bucket list things, one of the things that I said I'm going to do when I get there. So I got there. So now I'm like, okay, now here you go, because now you got to put your money where your mouth is. Yeah. So I took we had just finished our strategic planning process as a senior leadership team and the board. So the timing was great. So I took that, let's say there were four pillars, 4 areas. I assembled my team. I included some staff nurses, all my nurse managers and directors. And we had so every pillar had a senior leader sponsor. So I brought the senior leader sponsors in to share their vision for their pillar with my team, so that they actually got exposure to the senior leader who owned that pillar. And we spent a good amount of time talking about what this means, what does it look like. And then I cascaded down so we had the organizational strategic plan, and then we had the overall nursing strategic plan that was based on the organization one, and then we took it down to the unit level. So every unit had a big poster on their unit that said, here's what we're going to do this year, and here's how it connects to the nursing strategic plan, which was right above it, and then here's the organization strategic plan. Wow. So that every nurse could say, by doing this on my unit, by increasing our percentage of baccalaureate prepared nurses, by nurses in participating in shared governance committees, by whatever it was, here's how I'm contributing to the success of the organization. Yeah. So that's probably the one thing that's the one thing I'm the most proud of. Someday I keep saying someday I have to write an article about that. Like I've got to publish that.
That sounds textbook.
Yeah. And then I think the other thing was implementing a new role. So implementing a new role in nursing. Nursing hadn't had a new role for 10, 15 years. So the American Colleges of Nursing, I won't get too specific, but the American Colleges of Nursing created a clinical nurse leader role. Okay. So in a nutshell, our patient care complexity had changed. We really hadn't changed the way we deliver care in a long time. So we really needed to think about how are we going to manage these complex patients that we're taking care of in a very short period of time. So this was the clinical nurse leader role, and I advocated for, educated the board, educated my whole senior leadership team, and successfully implemented 2 CNLs for every unit in the organization. So to take a concept and bring it to implementation was one of the things that I was the most proud of, and without adding FTEs.
Okay.
Yeah, so I thought that was pretty good.
Nice.
The CFO liked that.
Yeah, I appreciate that. So, you came to Dartmouth-Hitchcock in December of 2015 to be the Director of Nursing Operations for the Norris Cotton Cancer Center, or the NCCC.
Yep.
What made you decide to leave the Elliott after such a long and successful run? I mean, you were a member of the senior leadership team, like you're talking about.
Yep.
Seemed like you were at the top.
Yep. So the decision for me to leave the Elliott was not mine. I had worked with the CEO for many years. I loved him. He loved me. We had a great relationship, and he retired.
Yeah. Is this Doug Dean?
Yeah.
Okay.
Yeah. He's just one of my mentors. He's a terrific, terrific guy, and taught me a lot. A lot of who I am is because of him.
Okay.
And so he retired, and then we had a new CEO come in. And it's not uncommon in the industry when a new CEO comes in to have leadership changes.
Sure.
But I certainly didn't anticipate that I would be one of those leadership changes. But I was. Okay. So I found myself, unexpectedly, I call it, released back into the industry.
Okay.
That's just, the way I have to look at it.
There you go.
So, you know what? Out of adversity or situations you didn't anticipate finding yourself in can come great things.
Yeah.
And I remember in those first couple of weeks after, I had lots of staff reaching out to me, like, oh my God, what are we going to do? And I said, what you're going to do is to keep on doing what you're doing. You're going to keep on taking care of patients. That's what you do. That's what you need to keep doing. And I would just say to them, the best thing possible that you want is a CNO who the CEO respects. That's going to be the best for nursing at the Elliott. And for whatever reason, that's not me. And so you're going to stay and you're going to keep doing what you do. And you're going to have a new nursing leader, and she or he is going to be respected by the CEO. And that's what you need. That's what you're going to do. Yeah. So I had to dig deep a little for that.
That sounds like, yeah.
That didn't come off like right away, but I'm thinking I was home thinking I have to know what to say because people were calling me and texting me, and I had to have a way to help them through it.
Yeah.
That was important to me, that they felt okay.
Right.
That it's going to be okay. You're going to be fine. It's good.
I've had conversations with CEOs and other senior executives, and very often that is the conversation is, I made changes coming in here because fit. It's just fit.
It is. And as I said earlier in the conversation,
it's not competence.
Fit is really it is really important.
Yeah.
Yep.
Yeah.
And I ended up in the place that I wanted to work my whole career, but never could because I was raising kids in southern New Hampshire. Okay. So I ended up in a great place.
Yeah. So here you are.
Yeah.
So you're actually not in the position you came to.
Right.
So let's just, so you did come to be the Director of Nursing Operations.
Yep.
Well, first of all, what is the Norris Cotton Cancer Center?
So the Norris Cotton Cancer Center is an NCI, so the National Cancer Institute. So we're a comprehensive cancer center. There are only 45 in the country, so we're one of 45 nationally accredited cancer centers. That's probably the best way to put it. And what that means is that we take care of, in an interdisciplinary way, we take care of patients with cancer diagnosis. So we have about, I think there's like 25 now, COGs, 25 clinical oncology groups. So that are interdisciplinary. So they're nurses, doctors, researchers, research nurses, pathologists, all kinds, any discipline you can imagine, kind of come together and kind of wrap their services around these populations of patients. So that's one hallmark of a cancer center, is a real interdisciplinary approach that includes the medical care, but also includes supportive services like, we have HARP, and we have HARPs, and we have massage therapy, and we have, sort of a lot of non-traditional modalities that we offer to all of our patients. So that's kind of one leg of the stool. And then there's the research leg. So we do a lot of clinical research here. So there's two kinds of research I've learned. There's clinical research where patients are on clinical trials and they may be getting experimental drugs as part of being part of research protocol. And then there's the bench scientists, which do the work in the lab. Okay. So not patient focused, but they're doing really primary research,
basic
with
research,
animals So
wow.
research is a big piece of it. So research, interdisciplinary care, and community. So we do a lot of work in our community. So I don't know if you've ever heard of the Proudy, which is sort of our big bike ride in the summer.
Okay.
It's not even just a bike ride now, but the Proudy is our main fundraiser for cancer research. Okay. And it's a big thing here in the Upper Valleys. So that's really what the Cancer Center is. So it includes all the clinics. It includes a couple of infusion centers, so patients will go once a week or twice a week or once a month for chemotherapy. So they go in, get their chemotherapy, and go home. And we have sites in Manchester, Concord, Nashua, and St. Johnsbury, Vermont, and the inpatient unit. So I also oversaw the inpatient oncology unit. So it was like the whole service of cancer services, all under me for nursing.
Wow. How does someone come to be under the care of the Norris Cotton Cancer Center? I mean, why? And I mean, obviously you have cancer, but how does somebody come to be under the NCC versus, say, some other oncology service somewhere else?
So a couple of ways. One, typically cancer is diagnosed or questioned by a primary care physician. So primary care physician in the community would then say to a patient, or if it's a Dartmouth, obviously if it's a Dartmouth physician, primary care physician, they're going to send our patients here. Okay. But we get a lot of referrals from other physicians in the community. So we might have someone in Vermont or in southern New Hampshire who say, based on the reputation of the Norris Cotton Cancer Center, it's a local, you won't have to go to Massachusetts, because some patients don't want to make the trek. Again, it could depend on geography. It could depend on reputation. We have a lot of really very well-respected oncologists that are nationally respected, so have national reputations. They published research, so that's another reason why somebody might say, I'm going to send you to see this oncologist because he specializes in this kind of cancer care, and I've had patients go to him and they've been really successful. Patients can self-refer based on our reputation and our research. So those are probably the primary ways that patients become a cancer center patient.
So what was the transition like for you to come up here?
Yeah.
So different organization, different role.
Yeah. It was great. And I'll tell you why. So when I left the Elliott, it was a pretty big ego blow. I needed to be in a place where I could feel good again about myself and my career. And the chief nursing officer here at the time, I was friends with because we were colleagues. Sure. And she was just another incredible mentor to me. And so I reached out to her and said, like in the summer, I did take a year off, but in the summer I said, okay, I'm thinking about getting ready to enter the workforce. I'm starting to interview across, I was looking at positions across the country, but, I'd really like to come. Can we get together? Can we get together and talk about, I'd love to work up there with you. Anyway, so long story short, that's how I ended up here. And the thing that was the most healing for me was coming to an environment where I was welcomed. It was like a big hug. Like, I hate to say that. I mean, I know that sounds really weird, but it was like a professional hug. Yeah. So I came and I was welcomed and I was respected, and people were like, oh my God, I can't believe you're coming to work with us. We're so excited to have you here. And so I came into an environment that for me was healing. Like, for me, it helped to heal me because I was not healed. That transition is hard. Yeah. And I think we don't talk enough about stuff like that. You don't got to be, put your armor on and be brave and, say, I'm fine. And someday I would love to, I was actually talking to another person in my position who got let go from a CNO position. And we are actually talking about writing a journal article together, because people don't talk about it, right? Because nobody, it's embarrassing, kind of. Yeah. So when I came here, I came into an environment where I was completely welcomed and respected and allowed to do my thing, to lead, and it's been terrific. It's been a great move for me.
Yeah. Well, it certainly seems to have worked out for you, because you were recently promoted to be the director of outpatient nursing and clinical operations for Dartmouth-Hitchcock Medical Center.
Yep.
And are you also still the director of nursing operations for the Norris Cotton?
Well, I
Cancer
am
Center,
just on an interim basis. So
Okay.
we're actually interviewing candidates over the next few weeks for that position.
Okay. So in the long run,
In the long run, they'll have a matrix reporting relationship to me, so I'll still be somewhat involved with the cancer center from a nursing practice perspective. So they'll still have a matrix reporting relationship to me.
Okay.
So that's cool.
So what is the scope of your new role as the director of outpatient nursing and clinical operations?
Yep. So this is a nursing practice position. So operationally, like as far as budgets and FTEs go, I don't have responsibility for that. The practice managers and practice directors do. So this role is like the funnest part of a nursing leader's job without all the, operational headaches. So now I get to really be involved in what should nursing practice look like in the ambulatory setting? What is the role of a nurse in the ambulatory setting? How do I support nurses who work in ambulatory care? Ambulatory care is really where the future is going, right? Because we're trying to shrink hospital days, move patients more to the outpatient side. So it's, in my opinion, it's sort of the new frontier for patient care. That's where nurses are going to have a lot of opportunity to really impact patients' lives on the outpatient side. So my scope, as far as geography goes, I have all of the clinics here in Lebanon. And then I have all the clinics in Manchester, Concord, and Nashua. So those are the locations that I travel to. Okay. So I spend about 3 days a week here, 3 to 4 days a week here, 1 to 2 days a week in the southern region.
Wow. Okay.
And so it's great. I've gotten to meet a whole new group of nurses and doctors. And so, yeah, it's a pretty big scope.
Yes,
but
that's
I'm
huge.
I'm not afraid of that.
And how does your current role fit into kind of the bigger nursing structure within the organization?
I know you've interviewed Karen Clements. So Karen is my boss.
Right.
So Karen is now the chief nursing officer. And then she has 2 directors, director of inpatient and a director of ambulatory. Okay. So I have a partner, Michelle, so Michelle and I report up through to Karen. Okay. And she's a great leader too.
She's a lot of fun.
Yeah, she is. She is. Yeah, she is. She's a great person to work for.
Good people, yeah.
Smart,
very
driven.
Smart.
Yep, she's great.
So let's talk a little bit about healthcare, maybe kind of in general.
Sure.
There's a lot going on in healthcare. We've got MACRA and MIPS and discussions about repealing Obamacare. Or the ACA, depending on what party you're with. And there seems to be just ongoing pressure for organizations to merge and consolidate. What do you think the major health policies on the horizon or are coming into effect now, how do they impact your day-to-day practice, or how will they likely impact your day-to-day practice?
That's a great question. There is so much uncertainty, especially with the change in presidential party in the White House. And, there's a lot of uncertainty about what that looks like or feels like. But even if that didn't happen, even if we stayed, with the party that was in the White House before, I still think the pace of change in healthcare, regardless of the political landscape, is hard to keep up with. So, we feel like you just kind of get your head around MACRA and MIPS, and now we have, in 6 months it's going to be something different. So the challenge is that healthcare organizations are not nimble. We're not known for change, quick change, thinking on our feet. We're not known for that. We're big, complex organizations, which makes it difficult to implement change. Some organizations are better at it than others. But that's one of the biggest challenges I see is, we've spent a lot of time thinking about population health and, starting and stopping and where are we going to go? And I worry that we're going to settle on what we're going to do and how we're going to do this. And then the rules are going to change again. So I think the challenge is figuring out how do you stay nimble, or how do you become nimble, and then how do you stay that way? And I don't have the answer for that. I wish I did. But I think that's one of the biggest challenges for healthcare is trying to figure out how do we take this behemoth organization and align it so that we're doing the right thing. And we're living in a schizophrenic world. So we're living in half fee for service, right? So half of our work we're getting paid by what we do, right? So more procedures, more money, right? But the other half of our world is capped, so sort of capped payment. So we're going to give you this amount of money for this many patients, and you spend it the way you want. If you spend too much, you pay out of pocket, right? If you don't spend as much, you get to keep it. So we're living in two worlds. So our payment models are, so you structure yourself based on how you know you're going to get paid, but it's hard because sometimes we have competing priorities.
Right.
So that's what I think is a challenge for health systems, is to try and figure that out. And we're not, we're doing that same story, we're in that place trying to figure out how do we do this and how do we do it and be financially solvent so we can take care of our patients, right? They always say no margin, no mission, no mission, no margin. You have to have both,
right?
So
you mentioned pop health. You're on the outpatient side, so that's got to be a big area you're engaged with. Tell me a little bit about what kind of projects you're working on.
Yep. So we're actually, I'm knee deep in this, I feel like. We, for our community practices in the southern region, have signed up for the next generation, which is sort of the newer payment models. And so we're just right now going through who are our patients? What do they look like? What is their risk? What's their level of acuity? And really trying to figure out how we manage them on the outpatient side. So, how do we take nurses, for example? So for nursing, how do we elevate the role of nurses so that they can practice I know this is a standard term, but practice at the top of their license. So how do we get nurses not rooming patients and doing vital signs and doing those things that somebody else can do? Those are important things, but someone else can do them. And how do we transition so that nurses are managing complex patients, touching base with patients, so that, how are you doing? Are you doing okay? Do you need anything? So that when they need something, they'll come to the office instead of needing something and going to the emergency department, which is a higher cost of care. So we're trying to figure out, what does that look like on the ambulatory side? What does it look like to be efficient and providing care at the right place at the right time? And again, if you think about that in living in two different worlds, how difficult that can be. And we really tried to take the model of being payer agnostic, right? So thinking like we just have to look at all of our patients as if they were managed, population health, like we're managing their health. We have to stop thinking about fee-for-service versus capitation. So we're figuring that out still. And that's a big part of my work, is representing nursing at that table.
You mentioned practicing at the top of your license. And it made me jump back to a earlier part of our conversation where you were talking about the two roles, your elevator speech about the two roles of nurses. And one of them being with the patients. Yeah. If you're going to kind of stratify the functions, are you worried about losing the being with portion? So if you're going to only practice at the top of your license, I'm going to do medication management, I'm going to do all these things that I'm trained for, and I'm going to push off bringing you your food. Right. No, I know where you're going. So my concern would be, I've heard a lot about this from physicians. Yeah. Right? Like I don't get a chance to spend time with my patients. Right. Run in the room, I make a diagnosis, I run back out. Are you worried at all as you push toward that? I'm not, because I believe that we have created spaces for that to happen. So, for example, we're doing post-hospital discharge. So when a patient leaves a hospital, there's evidence and research to demonstrate that if they're not supported appropriately in the first 7 to 14 days of being home from the hospital, they end up back in the hospital. Yeah. So that's a perfect place for a nurse to reach out to the patient, whether they're doing it by the phone, whether they have the patient come into the office to for like 3 or 4 days out, come in, let's talk, let's see how you're doing. Let's check the list that your patients that they gave you in the hospital. Let's make sure that it matches what we have in our records. We were able to fill all your prescriptions. Do you need anything? So I think it's just creating a different space for those interactions to happen. Okay. And then we also have care coordinators, so nurses whose job it is to work with patients on developing care plans. So we always think of a care plan as being in the hospital thing, but now we're starting to think about how do we work with our patients and say,
all right, you have congestive heart failure, so you have to manage your fluid intake. Now, when you're a patient in the hospital, it's easy because we control what we give you. Yeah. But now that you're at home, how can I, as a nurse, help you do this at home? So that, again, nurses are interacting with patients and saying, well, what can you commit to? What can you do? Can you, quitting smoking is, obviously a big concern. And some patients just say, I can't quit. And so instead of just giving up on that patient, you say, okay, but could you cut down 2 a day? And so working with a patient to identify goals and care plans, and how do we keep moving towards a goal that we collectively agree to. So I think that, to your point, that it just looks different, right? Yeah. That time and presence with the patient looks different on the ambulatory side. Yeah. Nurses will come in. We're going to have patients come in and do annual wellness visits. So Medicare pays for an annual wellness visit. It doesn't have to be with a physician. Physician should be seeing the more complex patient. Have a nurse see a patient for an annual wellness visit. Here's your blood pressure. What are your meds? How are you doing? Do you need anything? And then kind of connecting that patient to resources in the community. So I think it's just finding those new ways to do what we do.
So I wanted to ask you how you've perceived nursing changing over the 30 plus years you've been in the field. One of the things you talked about earlier was you said you were proud of having brought on the clinical nurse leaders.
Yeah.
So one of the kind of follow-up questions I had was the role of advanced practice nurses. Yep. Seems to be a big change in the time you've been in practice.
Yep. So again, those are responses to what I think has changed. Certainly is the acuity of our patients. So patients are sicker, they're living longer, which is good, right? Those aren't living longer is not necessarily bad, but we have so
Generally
many
speaking, it's on the better side,
right? Treatment modalities. We're keeping patients alive longer. Yeah. So that's number one, and they're staying in the hospital shorter lengths of time. Like now they're doing total joints as an outpatient. I mean, as an orthopedic nurse, I don't think I ever would have saw that happening. That you did an outpatient, you did a total joint replacement and sent them home. And there's lots of examples of things like that. So it had, so now we have a physician shortage, right? In addition to nursing shortages, but it's created this role for advanced practice nurses, which I think is fantastic. I'm a huge fan of advanced practice nurses, and the role that they play on our teams, so that there's a role for the provider. We need physicians, but partnering with advanced practice nurses creates a role for advanced practice nurses to be autonomous and independent practice, have an autonomous and independent practice, but working, alongside a provider. So I think it creates a lot of space for advanced practice nurses, which is great.
Can you give an example of a couple of advanced practice nurse types that you
see? So nurse practitioner. Okay. That's probably the most common one. Sure. Like that's what most patients would think of as an advanced practice nurse. And then, let's see, clinical nurse specialists, so nurses who work and kind of help manage populations of patients. A midwife is an advanced practice nurse. So those are formally advanced practice nurse roles. Okay.
If you could step back to UNH campus, just as you were about to graduate back there in the 80s, aside from, don't wear parachute pants and things like that, what advice would you give yourself about, what advice would you give to your 1984 self as she's about to launch on her career?
That's a great question. I think I would tell myself that there are going to be a lot of changes coming, and just stay true to who you are. Stay true to those core values that are not negotiable for you. Like, don't let yourself be detracted from those. Don't let yourself be sidetracked from those, and get ready for a wild ride. That there's a lot has changed. Yeah.
Well, let's transition and talk a bit about leadership.
Sure.
What would you say is your leadership philosophy?
So I would say that I consider myself sort of an authentic leader, I guess, if I had to put, some of the official leadership theories, I'd say either authentic or a transformational leader. But I could like to think of it sort of as I keep referring to my core values. Like, what are the things that are most important to me as a leader and as a coach and as a mentor to other leaders? And one is, and we've talked a lot about it during this interview, is the importance of situational awareness and emotional intelligence, the importance of relationships. So I cannot emphasize enough how important, in my career anyway, maintaining positive professional relationships are. That no matter how, no matter who or what level in the organization someone is, it's always important that you're collegial and kind and caring and professional and human, and that I have found for me that has served me well in my career. That relationships are important, and not from a self-serving way. Like some people will say, you never know when you're going to need somebody. That's not what I mean. I mean just being kind and caring and fostering relationships that are collegial and professional is so important. Like that's one advice I'd give to young leaders, is to never underestimate the importance of relationships. Vulnerability is I believe is a very important leadership quality.
Okay. That
being willing to say, I don't know, or I don't know, but let me find out, or being willing to say, I'm not really sure I handled that well. What could I have done differently? I think for me have served me well, and I think they're very, very important leadership traits. And it also demonstrates to your team that it's okay to ask for help. If they see you role modeling that behavior, then they're likely to reach out for help when they need it. Because honestly, one of the things that frustrates me the most is when someone doesn't reach out for help. Like I would rather have someone ask me for help than not ask.
Yeah.
So I think being willing to be vulnerable as a leader. But that's not what they teach you, right? When you're in leadership school, they kind of teach you have to be strong and you have to be the tough one and, put your armor on. I don't know if you've ever heard Brene Brown.
I have.
Love her. And I love her analogy about going into the arena, that you stop and you put your armor on and into the arena you go. And she kind of challenges us to take the armor off and go into the arena and be willing to be vulnerable as you're doing the work that you need to do. So I'm a huge fan of her work. I love her. But she taught me, she didn't teach me, she validated for me the importance of humility and being willing to kind of open yourself up and say, what can I do differently? What can I do better?
Yeah.
And then, just being passionate. To me, that's an essential quality of a leader, is because that's what staff, they feed off of that. If they see that you're passionate and you're compassionate and you love what you do, it's contagious. People like that. They want their leaders to be positive, and they want their leaders to be well respected, and they want their leaders to be, they want their leaders to be liked by other people in the organization. And that's important. Yeah. And then just being tenacious and persistent. Like I don't know where my sign is. Somehow it got lost in my moves, but I have a sign that says impossible just takes longer to happen. And I believe that. I don't believe anything is impossible. And that's how I roll. That's how I lead with, okay, so we can't get to here, but can we get to here? Can we, and my friend, my partner in life also taught me, you never tell someone what you can't do. You always tell them what you can do. And he owned his own moving company when I first met him. So if a customer would call and say, I want to move on July 4th. Well, that's not going to happen. But instead of saying, I can't move you on July 4th, he'll say, I can move you on either July 3rd or July 5th. Which one would you like? Or he'll say, great news. I have availability on the 3rd or the 5th. And it isn't a game. It's really, he just really believes, it taught me that lead with what you can do instead of what you can't do.
So you've hit a little bit of this, but I want to ask you, what do you see are the characteristics and behaviors of a good leader? And how do you aspire to those yourself? So you talked about vulnerability, authenticity, tenaciousness.
Yeah.
What else would you add to that list?
I think that although those are important, I think you also have to have subject matter expertise.
Okay.
That you can have all those things but not know what the heck you're doing, and that's not good either. So you kind of you have to balance that out with knowledge and expertise and knowledge of what you're doing, whatever it is that you're leading. I think it is important to be seen as a knowledgeable expert, even though you might not be, you might not know everything, but you have to make a commitment to knowing what it is that you're doing, kind of thing. Oh, and the other thing is, I think it's important to always share the why, like always share with people why, what you're asking them to do. And for the patient, because we're talking about patient care and nursing, I always try and connect what I'm asking them to do with a patient. So I'll give you an example. So in the ER, the first of every month, everybody hates the first of the month because you have to go through and you have to check all the code cards. And nobody likes to do it. It's tedious. It's not fun. It's boring. And sometimes you don't do it because you say, oh, I'm too busy. But I tried to help my staff understand why that's so important and connected that to either them personally or the patient. So I would say, imagine that this was your mother here and she was in cardiac arrest and the nurse went to open the code card and the meds that you needed to give that patient were expired. Yeah. And they wouldn't work. So just imagine how you'd feel if that was your mother in that bed. And alternatively, imagine if you're at that bedside and you're intubating a patient with Dr. So-and-so. And I'd always pick the doctor who was the jerkiest doctor and say, if he asked you for something and you opened the cart and it wasn't in there, just imagine that you're the nurse standing there. Do you want to tell him that it's not in there? Because, that's not going to go well. Right. Or I try and say, imagine that if only 1% of patients get this complication. That doesn't seem bad, right? 99% of patients get the right care, 1% doesn't. That, by all accounts, that would be, okay, pretty good average, right? But if 1% ends up being 12 babies who are given to the wrong parent, or 1% of patients who got the wrong procedure or the wrong pacemaker or whatever. So I always try and connect, even though what I'm asking you to do seems like routine and mundane, how do I connect it to the why? So that's what I try and do.
Can you give me an example of a difficult leadership lesson you might have learned the hard way?
Yeah, so I would say my most difficult lessons were at the core, like once you peel the onion back, were based on the same thing, which was my failure to address performance in someone. So I have different examples, but the failure of a leader to address someone's performance will never end well. Never end well. We have an obligation as leaders to actually one of my former mentors told me, you're either managing people up or you're managing them out. That as a leader, that's your responsibility, is to manage someone up or manage them out. And I think failing to act in either way is not good, or failing to make a decision when somebody isn't the right fit, that you've worked with them and you just are unwilling or unable to cut the cord, or to make the difficult decision. And it's really better off for everyone. And I say that now, based on our earlier conversation, seems like I'm talking on two sides of my mouth because I was the recipient of that. Sure. But I think those are my most difficult leadership challenges, were when I had decisions that I had to make that were really difficult and I knew they were the right thing to do and I didn't do it, or I didn't do it in a timely enough manner. Yeah.
Yeah, so that's one of the most common responses.
It is. Yeah,
absolutely.
Yeah. And it's hard because for me, when I hire someone, I feel a commitment to their success. Yeah. But in one case, I wanted this person to be successful, I believe, more than they did. Okay. And so that doesn't end well it has the potential to not end well for you because you're not managing appropriately.
Yeah. Well, so speaking of hiring, what do you look for when you're hiring leaders and also when you're evaluating them?
Yeah. So I look for passion. I look for caring, compassion, sort of all the things we've talked about earlier. I look for someone who I think is tenacious, who's not going to give up, when the going gets rough, kind of thing. Those are qualities I look for before clinical or content expertise. Yeah. And if I happen to have both, that's great.
Okay. You've worked in a number of different organizations here. You've You started down in Philly at Einstein. You worked through a bunch of different organizations within the Elliott. You're now here at Dartmouth.
Yeah.
Tell me a little bit about organizational culture.
Yep.
And why is it important?
So, as you know, I'm sure, culture is what's allowed and what's not allowed, in an organization, from a behavior perspective. What do we tolerate? What don't we tolerate? Kind of the ways of the world, like how do things work around here, the unwritten ways things work around here. I also believe that culture is not, to create a culture the right way needs to be intentional. So from a senior leadership perspective, from a CEO on down, I think creating culture should be an intentional thing. Because if it's not intentional, then it just kind of everyone kind of does their own thing. So I've had the opportunity to work in cultures where it's a healthy culture, and I've had the opportunity to work when there wasn't a healthy culture. And sometimes that can be in the same organization at different times over an organization's lifespan. And I would say that sometimes you don't realize the culture until you've left an organization. And for me, culture means doing what you say and saying what you do. Culture means when you're in a healthy culture. Let me clarify that. So a healthy culture means when you're in a meeting and you all make a decision, that's the decision that gets implemented. And an unhealthy culture is when you're in an organization and you have a meeting and everyone says this is what we're going to do. And then there's 3 or 4 meetings outside the meeting and the original decision gets changed. So that's what I personally would consider to be an unhealthy culture. Like, I want to work in an organization where we say what we mean and we mean what we say, so that when we all agree to something, that's what we all agree to. And so culture is really important, I believe, as a leader, and culture can result in people not feeling like they're a good fit, or somebody thinking you're not a good fit. And I think a lot of times culture plays a role in that, because it's hard to trust and develop trusting, honest, respectful relationships when you don't do what you say and say what you mean. You don't mean what you say and say what you mean. Does that make sense?
It does.
So I think culture is really important, and it's very different. It can be very different organization to organization. And it's not good. It's not bad. It is what it is. But I think it's important, especially as a leader, to ask those questions. What is the culture like here? Sometimes people will tell you things, and then you'll learn, that's not what I see, so... But I think it's an important question, especially for leaders thinking about joining an organization, is understanding that at least what do my people who I'm going to be working with think the culture is like here. Because sometimes you might make a decision not to join that organization, depending on, again, going back to, does that really fit within the kind of place I want to work in? So I think those are important. It's hard. It's not objective. It's very subjective, but it's still important conversations to have when you're thinking about either joining or being part of an organization or staying with an organization. So,
you've talked about mentors a couple of times. I think you said Doug Dean was a mentor. You said the CNO here had been a mentor.
Yep.
What does a good mentor do?
So, I think a good mentor creates a safe place for a mentee to be able to talk through challenges or issues or concerns or potential for your further career growth. I think a good mentor creates succession plans, right? So grows new leaders. That's probably a better way to put it. But a good mentor is committed to helping someone to be what they want to be. So to get where they want to go. And I think sometimes provides a different perspective that a young leader might not think of. Like I always tell people, don't think of just your space as a leader. Don't think you have to just be a leader in your department. So if you want to be a leader, let's look at, we have a whole organization here. Let's think about maybe you could consider this type of a position. This is a leadership position. So really helping someone see the possibility, helping a mentee see what's possible, and just providing guidance and coaching and direction and sharing expertise, sharing removing obstacles or sharing your experience and saying, well, this is what's worked for me, or this is what hasn't worked for me. So I think I love, being a mentor.
Okay. So that was my next question is, do you mentor other executives, either nurses or other people now?
Actually, Dartmouth has a formal mentoring nursing at Dartmouth has a formal mentoring program. And they've done 2 sessions so far. I was involved in the second one in December, where it was kind of like a speed dating thing. So what we did is they had like half and half. So half people who are willing to be mentors and half young leaders who were looking for mentors. And then the morning part of the day was around what is mentoring, what are the value, what are the benefits, what does it look like? So it was sort of the content about mentoring itself. And then in the afternoon, you did like a speed dating kind of thing. And then at the end of the day, they paired up mentor and mentee. And then we're in the middle of now our 6-month relationship, where you get to meet with your mentor over time or your mentee over time. And it's actually our Nursing Transformational Leadership Council. So this is clinical nurses, staff nurses, who put together this workshop, and it's been fantastically successful. So I think they're planning their next one for the fall.
Nice.
Yeah.
And so it's a 6-month relationship, and then
it's a 6 months, right? It's a 6 month structured relationship, and then like I believe that my mentee and I will maintain that. It's hard. You don't just end it. You know what I mean?
Right.
So yeah, it's and I thought it was kind of funny when I signed up for this conference. I thought it was just a conference on mentorship, like on mentoring. So I signed up for it.
So it was like a lecture.
Well, yeah. So I was in a meeting, and someone's like, "Oh, I'm so excited you signed up to be a mentor," and I'm like, "What did I do?" And she's like, "Yeah, you signed up to be a mentor for the conference," and I said, "Oh, okay." And then I'm like saying to myself, I got to look into this inside. I just said, "Oh, yes, I can't wait. I'm looking forward to it." And then I get back to my office, and I'm like, "What did I sign up for?" But it's been terrific. It's very rewarding.
Very nice. So we're sitting here in your office at your table, and on the table you have a couple of leadership books. So one of my questions is, if you were going to pick a book to recommend to early careerists, in particular people who are interested in leadership, what would you recommend?
So I have 2 books, and neither one of them are on my table here.
All right.
So the first
one, good ones on the table.
I do, I know, and I leave them out so people can take them. So I have a whole bunch over there. So they take them and bring them back because I love leadership books. So one of my books is by Ben Zander, who he used to be the conductor of the Boston Pops. And so he's not a healthcare leader. Nope. And his book is called The Art of Possibility. And he just talks about thinking about what's possible, and I'll tell you his story. So this is the story one of the stories he tells, it's short, is that, so there's this executive that owns a shoe company, and he has 2 of his salesmen to go to Africa to sell shoes. So the 2 salesmen pack up their stuff, and off to Africa they go. So they get to Africa, and the first salesman calls his boss and says, "I just got here, and they don't wear shoes here, so I'm headed home." So he heads home on the plane. And the second one says, "Oh my God, you're not going to believe it. They don't wear shoes here. I'm going to be here for a long time." So he saw the possibility, right, of selling shoes to this whole country that doesn't wear shoes. And this guy was like, "Yeah, they don't wear shoes, so I'm out of here." He is, if you ever get a chance to see Ben Zander talk, he has a YouTube video.
Oh, okay.
So I first learned about him when I was dating my boyfriend, and he sent this to me and said, "Will you give up 20 minutes of your life to listen to this video, and I want us to talk about it?" So anyway, so he's just all about creating a possibility. He talks about a conductor. A conductor doesn't make a sound, right? A conductor does not make a sound, but he gets his work done through others, through leading his team. So anyway, so that's one of my books. And my second one is by Liz Wiseman, Multipliers. You must have heard about that book.
I don't think I have heard of that one.
So I have that book, but she talks about there are 2 people in the kinds of people, multipliers. So a multiplier makes everyone around them better. So a multiplier is someone who creates energy and passion and positivity around them, and they promote their team versus themselves, so they make everyone around them better. So I can think of a few people in my career who they, just by virtue of being around them, you feel more accomplished and you feel better and you feel good about what you do. So again, not healthcare related, but really important to me as a leader. So multipliers and the art of possibility. So those are the two books that I would say are really important. And I actually met Ben Zander in person.
Yeah.
And he is just a fantastic person. So if you ever get a chance to meet him, he has shining eyes. He's the one that talks about shining eyes and what shining eyes mean. It means passion and energy. And so
in conclusion, what advice would you give to early careerists who are embarking on a career in healthcare management? So either maybe a young nurse who's decided he or she wants to become a supervisor.
Yep.
Or, I teach mostly undergrads who are interested in healthcare administration. What advice would you give them going out?
Yeah. So I would say one piece of advice I would give is to find something that you're passionate about. Find something that adds value and makes your life better. Because I believe that we spend a lot of time away from people that we love at work, right? So if I'm going to leave my kids or my family, I want to be somewhere where I love what I do. So that's just number one. I told my kids that it doesn't matter what you choose to do for your career, find something you're passionate about and do it so that it doesn't feel like work. So that's number one. I would say don't underestimate the value and importance of relationships. So we've talked about that a little bit earlier. Don't pass up opportunities to become involved and be open to becoming involved in things that may not be within your, what you envision. So don't ever pass up an opportunity if someone says, hey, would you like to work on this project with me? If you can, and it provides you exposure to other people in your organization, whether they're in leadership positions or not, take advantage of that. That's a really good way to network and to be seen and to be respected and to be, valued as someone who's willing to kind of roll their sleeves up and get involved in things. And then I would say don't be afraid to boast a little bit about what you've done. I think sometimes we don't always toot our own horn. And I think that there's nothing wrong with that as long as it's not coming across as being arrogant and boastful. But there is nothing wrong with kind of promoting yourself a little and saying, hey, I just want you to know I've been involved. I've been working, let's say talking to your boss. Hey, I want you to know that I'm working with so-and-so in this department on this project. Just, it's okay. Or tell your boss's boss what you're doing. I guess those would be my big ones.
Great. Well, thank you so much for your time today. This has been really great.
Yes, thank you. I've really enjoyed talking. I hope that I've been able to add something of value to your class and to future leaders.
You've been listening to the Health Leader Forge, a joint production of the College of Health and Human Services at the University of New Hampshire and the Northern New England Association of Healthcare Executives. Please go to our website, healthleaderforge.org, for more information or to leave comments about today's podcast. Look for Health Leader Forge podcasts on iTunes, Stitcher, SoundCloud, and other podcast distribution sites. Thanks for being a part of the Health Leader Forge community, and we'll talk with you again in about 2 weeks.